My name is Dr. Edward Ngwenya, and we continue with our head and neck discussions. And also, I guess this we can mix it with aesthetics, because today's topic is hair restoration. Or rather, let's say issues to deal with hair. I want to touch on here number one, in cases of alopecia, when we want to restore hair, as that is one of the commonest reasons that patients as pertaining to hair may then come. However, there is another part which relates to hair removal, which perhaps we can touch on at the end. As I always say, it's up to you to go back to have a look at your books, to read upon the topic, and have, an understanding more in depth, as this does not seek to replace your learning, but rather to augment it. And it takes into, under the assumption that there is some core knowledge therein. Important that I always emphasize this in all my talk. We must know what the normal is in order to know what the abnormal is. And in order to be able to manage something, we must know the details therein. In other words, what am I saying? Excuse me. We must know the embryology, the anatomy, and then lastly, but more importantly as well, the physiology, as that will be the guide in assisting us in managing any patient. So hair restoration, let's talk about it. So what is the embryology of the hair? Now, we're not going to spend too much time. Excuse me, I've got something in my throat, but we're not going to spend enough time, too much time on the embryology. Suffice to say that the hair follicles originate from ectoderm and mesoderm, and generally around the third gestational month will we then find this happening. The anatomy is important to understand how it's structured. It's important for you to just open your textbooks, have a look, but just on a brief overview, the hair shaft is made of keratinized proteins. Now, these are several layers which include melanocytes. There's the hair bulb, there's the papilla, the hair shaft. And as you draw this unit, you'll be able to then appreciate. We've got the skin on the outside, the epidermal layer, which is continuous, and then goes down, and then we have now our sebaceous glands, which are then formed also here. But remember, on the sides in the dermis hypodermal region, we also have the sweat glands that are also there. And then right at the bottom of our hair shaft, leading all the way at the bottom, is what it's the hair bulb. And therein there will be an area known as the papilla, which contains your capillary loops. So that is important to know. So when we speak about the follicular unit, what we are saying in essence, it's a discrete anatomic and physiological entity of either one, two, or three, or four terminal hairs in their natural distribution. So what am I saying? One, two, four terminal hairs in their distribution. There's one vellus hair, there's 9 sebaceous gland. Generally, you'd get, insertions of the erector pili muscle. Let's not forget that. Your perifollicular vascular plexus, your neural net, in the perifollicular region, and just the perifolliculum is important to know. And on average, the human scalp has the numbers that will then come. It's about 100 to 150,000 hairs I don't know who sat and counted, but generally that's what the scalp then has, and you'd find it varies within the different Fitzpatricks. You'd find that the higher one, redheads on average, have slightly less hair. And whereas blondes on average have slightly more hair, which is just quite interesting. But there are as many hair follicles in a bald scalp as there are in a non-bald scalp histologically. So don't look at someone who's bald and assume they don't have. Histologically, they have hair follicles. And there are different stages of growth physiologically that will take place. We divide those in three. The first being your anagen, anagen, anagen. That's 90% of the cases, the anagen, looking at the phases they're in. Then you have your catagen, which is 3%, and then your telogen, which is then the remaining 10 to 13%. And the anagen basically is the active growth phase. So here you find active growth, your follicular cells are actively multiplying, replicating, and they're becoming keratinized. And this will last on general, they'll tell you 1,000 days in men, but in females it goes a bit longer, 2 to 5 years in women. Now, after that, you're then going to have your catagen. Your catagen generally lasts 1 to 2 weeks, or even 3 weeks. It's known also as the degradation phase. And this you find, the keratinization of the hair base. In essence, what happens, it forms a club, and you'd find a separation of the base from the dermal papilla, and it then just moves towards the surface, and that would last 2 to 3 weeks. And then eventually after that, you'd have your secondary germ right at the bottom, and your club going all the way upwards. And then you get a phase known as telogen, which is the resting phase, where the hair then sheds. The follicle is inactive in this phase, and the hair simply stops growing, and this may last, up to 4 months. And on average, 50 to 100 telogen hairs would generally fall each and every day. And I think that's enough. Perhaps they may vary. Generally, when the anagen phase shortens, you'll find that the telogen phase is prolonged. In other words, what we mean is that the rate of hair loss would exceed the rate of hair growth, thinning, and eventually baldness would develop, which is alopecia. So let's get into alopecia without wasting time. And this is something very common. As I started, mentioning their stats, giving you numbers of 35 million men, 21 million women in the US who have hair loss. And 33% generally of men you'd find actually seek hair replacement surgery. And this has been found, even as high as coming in, by their mid-30s, and then create about 50%, of alopecia about 50 years of age, 66, 60 years of age. So it tends to follow this. But we see a higher incidence as per the studies, in your white, Caucasian, followed by Asians, and then, the black population. And Indian population is found to be at its lowest rate therein. And the etiology varies. Most common, it's hormonal related, and we call that androgenetic alopecia or androgenic alopecia, and that's 95% of the cases. Especially when we look at, your male pattern baldness, which generally, it is affected here, and this is in fact X-linked, a dominant condition that then happens. And the hormones, I'm not going to get into it, but we know our 5 alpha reductase, which is in the cells of susceptible hair follicles and skin. And this is responsible for, converting testosterone to DHT, which is dihydrotestosterone. And so what you then find is that the normal circulating amount of testosterone may exceed, or rather may, be converted in an excessive amount to DHT, or the hair follicle may be abnormally sensitive to DHT, and this will then create your androgenic alopecia. So it's generally because of these testosterone levels, or the susceptibility or sensibility being much higher. And so you then get your male pattern baldness, and we classify this, using the Norwood classification. We'll get into it. What are the other causes? It can be non-androgenic. So because we know androgenic is the majority, the other causes we label them as non-androgenic. And this would include alopecia areata. We don't know what this is caused by, but we know it involves the perifollicular lymphocytic infiltration. And so what happens, you will see generally male, females affecting them equally, but what you will see, you get these exclamation mark hairs. It's generally unpredictable. It's quite spontaneous. The recovery may be spontaneous. So also is the recurrence therein. So that's something just to know about your alopecia areata. That's the big cause. Of course, the exclamation mark hairs can also be caused by, your trichotillomania, your, thallium poisoning, etc. But generally, you would see this thin, shafty distally. Just maybe Google a picture and you'd be able to see what an exclamation mark hair looks like for alopecia areata. Then we've got, patients who may come in with diffuse shedding of the hair, and then suddenly it spontaneously recovers over several months. And this may be induced by stress, hormones, medication, or whatever it is. This we call your telogen effluvium. Telogen effluvium. It usually, is self-limiting. And then there are other causes. I know specifically in our population, when one looks at certainly one's practice, we see a lot of women who will come in with your traction or traumatic alopecia. And generally, we find in our population it's related to, hairstyles, but it can be also, related to trichotillomania, which is what? It's the compulsive pulling of the hair. But your hairstyles, they generally give this traction alopecia, and generally in specific regions, we know from the back, and also affecting the periphery and the frontal region. But there are also metabolic disorders you must exclude, such as, your iron deficiency, thyroid disease, PCOS, which is polycystic ovarian syndrome. You rule out infectious diseases such as herpes, whether simplex or zoster, any fungal infection that you may have, like your carry-on, or any other causes, that may cause this to happen. Medication, beta blockers, ACE inhibitors, even birth control pills can so happen. Remember, we spoke about the androgenic component therein. But do not forget sequestratial alopecia. And this, generally secondary to scarring and follicle destruction. And so, for this to be able to diagnose, a biopsy would then help. And we see this a lot in our burns patients who then have this cicatricial alopecia. Note also, there is primary cicatricial alopecia from lichen planus, your lupus, erythematosus. So those are generally other causes that may be there. And then we classify our, hair loss. The males, we used to use the Hamilton classification. They described it in 7 major types. But what I use and what we generally use more is the Norwood modified classification there. And basically, when you look at Norwood male classification of alopecia, it divides it into 7 types. Type 1 being, just minimal or no hairline recession. And where does that happen? We all know it's in this frontotemporal, temporal region. And so there's type 2, which is then, symmetrical triangular frontotemporal recession that then happens the same as type 1. However, this happens and goes a bit more further back, but it's not more than 2 centimeters anterior to the coronal plane. And then we've got type 3, which is the same symmetrical, but it's more than 2 centimeters to the coronal plane. And then we've got your type 3 vertex, which is, primarily hair loss that's accompanied by that recession. But onto the vertex only being involved therein. This type 4, which is sparse or absent hair in the vertex, with more severe temporal, frontotemporal recession, and then 5, which is just the same as 4, but just more severe hair loss. And then you have your type 6, where there's now just a band, or there may be 2 areas of interconnections, but more or less in type 7, then you've got your vertex and your frontotemporal region now connected, and it's just one boldness going on there. Definitely much more complex, but easy when you then just use it every single day to then see. There is a female classification there in as well. So just for you to have a look at, it's the Ludwig classification that's commonly used, and it just divides it into 3 grades. Grade 1, 2, and 3, depending on the level of hair density. It's either, it's thick hair density, and then it goes on and becomes much, much thinner than going down. Generally we see it. You may look at the causes, by examination, and there are different ways that you can investigate if need be. And you want to exclude other things such as, using a scalp biopsy. There's also others who use, a unit area trichogram that they look at that region. And then there's more global, methods of, hair pull tests that you can use, analytical methods that you can use, by using a folyscope, handheld devices and all of that. But generally, you are able to make a quick diagnosis. And the way you want to manage it, which is what the patient then wants standing in front of you, will be divided into 2 therapies. Either, non-surgical, which is medical, or laser treatment you can then put, or surgical therapy. Now, what are then, let's go through the medical therapies that we may then use to treat this. So the medical therapy, we look at generally, your minoxidil. Minoxidil, or Rogan as it's known, is available in 2 to 5% topical solutions, and you use it on the scalp, at a BD dose twice a day, and it's cosmetically, useful. But the main thing is it must be used indefinitely if you want to maintain the response. There are other things such as your 5-alpha reductase inhibitors, like your finasteride, your also known as Propecia, And this is also one thing, but also must be used indefinitely. In notes, other things have been mentioned, like your spironolactone, and as other modalities that may be used in assisting one with this. Then I think another thing we can then look at is laser. I'm not going to talk too much on laser as I spoke about it quite a lot. We've got a special topic specifically on laser where we then discuss this. But in this, it just, it promotes, or rather, it's shown to be a preventative measure against androgenic alopecia. And it just if you look at the studies, they say, look, it thickens and induces growth of existing follicles. But be careful with laser. If you're gonna mention it, know what the different types of lasers are, what are the chromophores that will be then targeted therein, because you don't want to take chances in this modality if you're gonna then use it. As you know, you want your low level lasers for this, as it to assist you in this. You don't want to go into your ablative forms of laser for this. Okay. And so then we go to surgical options. Now, when we go to surgical options, you got to choose what you're going to do. We can do one of two things. We can say, look, what we want to then do here, we want to, we've got this in the scalp, and so we then want to then see how are we going to match the other side. And so some say, look, you can surgically excise, in other words, called alopecia reduction. So if you've got leg skin there, you just reduce that, cut off the area of alopecia, and it's reduction. Others say, no, man, we don't like that. Rather than use, tissue expansion. And if you've got one area, especially in burns and kids, one area that's burnt, you can then resurface the other area using, expanders. And you can actually close up to 50% of the scalp using this. And then, of course, there are other things such as scalp flaps that you may use, whether you advance your flaps, or you do free flaps. And then, there's free autographs of the hair scalp from head regions, moving them to areas that are non-hair bearing. So these are just some of the techniques. And then the big one, which has really taken off, and which most patients will come, they will say, I want a hair transplant. Hair transplant is the thing. And so what is hair transplant? So how will you do hair transplant? Well, I think I'm going to be simple and just split it into two things. Either you are going to do, strip grafts. Now, this is when you take an elliptical slit or excisions, and then you go and transplant it in another area. Or we are going to use follicular unit grafts. Now, herein then we will divide. It's either we use micrografts or mini grafts. What's a micrograft? Micrograft, it contains 1 or 2 hair per graft. What's a mini graft? It contains 3 to 4 hairs per graft. That's all you need to know. And so, of course, you prepare every patient well, and what you then do, the site that you are going to mark, or the donor site, basically, generally, the best donor sites will be the occipital and temporal region. But the prime area, or the precise anatomical location, best would be marked between the occipital protuberance and the superior nuchal line. And there, on that region there, posteriorly, you will get a good, sample. We'll divide it generally in patients older than 40. The donor site is in the lower half. And then if, patients are younger than 40, we look at the upper third as the donor site. What are we using? The occipital protuberance superiorly and the superior nuchal line. And it would be that elliptical area that is there. And as I've mentioned, you do your strip excisions. How can you do them? There are special blades actually that you can then use, called, your triple or quadruple blade knives. And they just, blades. They've got 2 millimeter parallel excision across the scalps that you then make. They are structured in that way, and it makes it easier to then cut and then close that region. Closure of the region is important. We used to use the old style of closure where it's a straight linear excision and you close it. But now what's favored is trichophytic closure, where you close it diagonally there, so that we line our hair follicles, and it makes it easier for the growth therein. And what then? How do we remove the follicular units? It's basically you use a refined micropunch graft, and that, if you look at one follicular unit, you would need about a 0.8 to 1.5 millimeter punch. So it's almost like a punch biopsy. You go there, you take, and the donor sites, you let it heal by secondary closure. And which is better to use? Whether follicular extraction grafts or the triple. What we found is that if you put them both together, actually, the mixed slit, with the holes, as you mix them together, you actually have a more natural look and better outcomes therein. And that would be the way you then fix it. Operatively, of course, you cover your donor site, with a non-stick dressing that you wrap around the head. You keep the patient approximately an hour after surgery, give oral fluids, observe them. It is a day procedure. They can go home the very same day, and they should be encouraged not to engage in strenuous exercise or heavy lifting for just at least 2 weeks, and also avoid direct sunlight. And when they wash their hair, just to use, the pour in inverted commas method, rather than scrubbing there. And they just follow up generally a week after surgery. But you tell them, look, your full results, you will see them in about, 8, as far as a year, 12 months. Just know there are complications intraoperatively: hemorrhage, lignocaine, toxicity, edema, folliculitis. But post-operatively, there may still be hemorrhage, infection, and dehiscence. But specifically for our population group, we need to counsel on the scarring and the poor hair growth. Sometimes there may be an unnatural hairline, kind of having a doll's head appearance, but those are some of the things you'd counsel then your patient on. And these are the measures for hair restoration. Now there comes a patient who says, look, I've got too much hair in a specific region. I want, techniques to assist me with hair removal. And so basically, we can say you can use two methods. Either you can use the physical method, to temporarily reduce those hair, your blacking, your shaving, your waxing, your electrolysis, but it's best used in limited sites. They cause a lot of pain, and erythema around. But we know the hair loss is not permanent. It's going to then come back. There are topical creams we can apply, such as, I think, your Venica, is the way VANI, I think QA. That's your creams, basically your eflornithine creams, 13.9%, and they just inhibit ornithine decarboxylase. And this has been approved for reduction of unwanted hair, generally in women, when applied twice daily. And it's a slow process that eliminates, or rather decreases hair growth. But patients must be appropriately counseled to comply with their medication, and just let them know that, look, it may be slow onset, and they must be patient as per the results. And then laser application. Remember, we spoke on lasers on the other side, but here also, it is currently, I know, on our side, the most popular and effective way to achieve permanent to semi permanent reduction of hair. And you can remove, more hair with less pain and requiring fewer sessions than your electrolysis. In fact, if you look at studies, they quote values as high as 60 times more effective. And he said generally you would then target a chromophore melanin. So we know that the mechanism of action will be dependent on that, which uses selective photothermolysis. And what would I then use? You use anything generally between 600 to 1100 nanometers. So that would be what your Nd:YAG, which is about 1064. Your even if you use your Q switch, Krypton one, which is about 650, that would give you the same result. Alexandrite, Ruby, Krypton, as I've mentioned, even pulse light devices. Just have a look at them as the ranges go from 510 to 1200 nanometers. And that would, I think, handle hair restoration and the issues we may then have. I thank you for your attention, and we look forward to the next aesthetic topic. Bye.